Anyone want to make comment or question to the board?
Any comments?
Hearing none. Let's take a look at the minutes from last month. Anybody have comments or changes?
Move to accept.
Second. Did I hear a second?
Second.
Thanks. All in favor?
Aye.
Any opposed? Same sign. Hearing none. Mr. Forte, it is your turn.
All right. Well, thank you and good morning, everyone. Got quite a robust report for you all this morning. It's been a chaotic month and almost a half. At the end of the day, our mission, our culture, our organization has an underlying culture of respect, belonging, and compassion for all. And so regardless of what chaos comes out of the District of Columbia, Helena, or elsewhere, we're going to be here. We've already been here for 50 years, and we're going to be here for the next 50. Our mission, our vision, our strategy, our plan is not dictated by external circumstances. It is the foundation of what we do, who we are, and what we stand for as an organization. So RiverStone Health doors will always be open to anyone from every walk of life and situation, and we will continue to serve them with dignity, care, and respect to meet their needs. A couple weeks ago, Dr. Littlefield and I were in Washington, D.C. For the National Association of Community Health Centers Policy and Issues Forum. We had the opportunity to connect with all 4 members of our congressional delegation, educate them on the benefits of public health and community health centers, as well as convince them that we are going to be a large part of this Make America Healthy Again MAHA movement coming out of Department of Health and Human Services. So we're going to continue to make clear that our efforts here, our community health centers, are the best part of the American healthcare system. A couple weeks ago, we had several Trump administration executive orders impact our work. And so we had about $1.7 million frozen within the federal payment system known as PMS. And we have made significant strides meeting our financial goals as an organization with the help of the board and the help of our fiscal team. But these freezes could have been catastrophic and were catastrophic. Several nonprofit organizations and community health centers across the country. Several community health centers have already needed to close their doors as a result of federal funds being frozen, not here in Montana. One health center here in our state has had to lay additional staff off as a result of the funding freeze and funding uncertainty headed forward. And others across the country have had to perform layoffs, service closures, and other drastic changes because of the uncertainty. And so our message to our congressional partners was help us take care of the uncertainty that exists. Help us eliminate that uncertainty, provide us with some continued long-term funding within the Public Health Services Act, and make sure that we can continue to meet our patients' needs and our clients' needs across this community. Working with Senator Daines and his staff, we were able to unfreeze those funds in a short period of time and maintain that money continues to flow to RiverStone Health. However, we are preparing for a pending government shutdown, because it seems like the Senate and the House federally will not be able to get their act together and move on budget reconciliation before March 14th. And we're also awaiting congressional action on Medicare and Medicaid programs nationwide. So Representative Zinke, again this morning, made the statement and assured Montanans that Medicare, Medicaid, and Social Security are not up for negotiation. But we will see what plays out on the federal level. So we're just going to continue to try to take our own financial destiny into our own hands and do everything that we can to ensure some stability. While in DC, I also attended a full day program on 340B. 340B is the part of the Public Health Services Act that requires pharmaceutical manufacturers that participate in Medicare and Medicaid to sell outpatient drugs at discounted prices to our organization. That program has been around for years and continues to provide funds for health centers like RiverStone Health and organizations like ours to take care of the neediest in our community. It allows us to provide services and put that money we save on those medications back into direct patient care and direct public health services. The Inflation Reduction Act of 2022 now authorizes HHS to do some drug negotiations. And pharma, in their infinite wisdom, has been changing some drug pricing and other strategies to combat those negotiations. And we will see impacts within the 340B program. And so we're anticipating, starting in calendar year 2026, that we will see about a $500,000 to $600,000 dip in 340B monies coming back into RiverStone Health to allow us to continue to provide additional services. So doing everything we can right now, again, to plan for and budget for a dip of that size and expect the worst, but hope for the best. So we'll continue to make those plans. Good news, during a recent snowstorm, included in my report, one of our hospice volunteers answered the call. One of our hospice nurses got stuck on a snowy driveway, and one of our volunteers named Alan made a trip to assist her to get unstuck, then also brought supplies to a patient and trudged through the snow up to the house on a cold, blustery day to meet the needs of our patients. So just incredible work being done out there across the organization by members of our team and our volunteers. You know, we've talked about the mobile unit and the mobile healthcare program that we're going to begin. We can now announce that the RiverStone Health mobile unit, future name to be determined, will arrive in April 2025. So we'll be able to begin planning and scheduling that unit to go out around the community, visit our local schools, as well as other rural communities across the county and the region to provide behavioral health, dental services, and medical services wherever they should be needed.
I have a question for you,
Yeah.
because it's a fairly large county and a fairly large need. How do you prioritize? Do you start outward, work inward? I mean, what's the thing? I'm just more curious than anything.
It's kind of where we have relationships already across the county and in different rural locations, rural school districts and things of, hey, here's a service that we can offer. I think that conversation we had with the chamber earlier this week brought to light some opportunities to get out there to some other rural communities and partner with some other entities that could help sponsor a visit by the mobile health unit. So I think we're going to get out there, see where the need exists, advertise that this asset is here in our community, and kind of schedule and go from there.
One sort of a quick follow-up question. So it's conceivable that we could, to help defray some of the cost, is a town wants to sponsor it, or a community wants to sponsor it for a day or 2 days.
Yeah.
And so they provide sponsorship dollars to help defray some of our costs with it.
Well, also worked with some of our local critical access hospital affiliates around the region, and they've had some conversation. I've had conversations with our Montana Hospital Association region and have generated some interest on dental services specifically, and things that they don't currently offer that we could come in and help them with.
John?
Yeah.
A lot of funds to support this came from the grant, the Fortin Foundation. Who prepared the grant?
So that was between our grant writer and our prior executive director for the foundation. So Megan Iron and Sarah Brock. Both former.
Both former, so we can't thank them for their efforts.
But I think that there's enough staff remaining that carried the water and did a lot of the work that we can.
I think on behalf of the board, they ought to be thanked. That's an important contribution to support this vehicle, or whatever we want to call it.
Absolutely.
Uh,
Thank you, Michael. Also, any high school students interested in behavioral health or just healthcare careers, 2 summer camps are coming up. The one on my report is the Heads Up Camp. That is a behavioral health focused camp. It's a 3-day camp. Overnight accommodations are free at MSUB, August 3rd to the 6th. And so folks can come in from across the state. I know we've had kids from as far away as Libby come down and come to our MedStart camps. And so the Heads Up Camp is behavioral health. The MedStart Camp is all healthcare allied professions focused and clinician focused. And so if you know any high schoolers or students that are interested in learning more, want to hop into our high school to healthcare pipelines, please share the information on those camps. Latest and greatest article from the Billings Gazette. The Billings group in charge of tax dollars for jail diversion folds after years of turbulence. If you haven't read it, you can go find it. But that was talking all about Substance Abuse Connect and the pending outcomes of our transition. And so in January and late last year, we were meeting with Zach Tarkitis from the Billings Community Foundation about a transition plan for those efforts, the crisis diversion grant, as well as mobile crisis and other mental health, behavioral health functions. And so we agreed as a local health department and someone who is, adept at coalition building and bringing people around the table to bring the crisis diversion grant funds and programming to RiverStone Health. And so it just makes sense that this programming lives within the health department and is partnered with existing partners that we already have and work with on a regular basis. And so to move things forward, we are going to be retiring the SAC Substance Abuse Connect name. It just has stigma associated with it. And so we'll be rebranding these efforts with crisis diversion, mobile crisis, and other services at a later time. But first and foremost, we will be hiring with the grant funds, posting a position and hiring a coordinator position. That'll be a behavioral health systems improvement specialist and coordinator for this coalition work. That's going to be first and foremost. Second, we recognize the need for and the desire for a functioning mental health crisis response model. And so begun conversations with our Community Crisis Center and Mercy and the great work that they do there, as well as other partners around this community that tried and didn't meet success with mobile crisis response. So I think as a community, we've got a lot of lessons learned. We're going to be continuing conversations with fire, EMS, police, city and county leaders, and working on a more cohesive 911 dispatch process and other processes to build a stronger infrastructure to sustain community crisis care and mobile crisis response in Billings and Yellowstone County. That is not going to happen soon, and it is not going to happen alone, but we're going to work through it and work towards that. And I think the most other important thing to know is that the crisis diversion grant funds are still being dispersed. There are several community partners engaged in that work that are receiving those funds from the county and will continue to receive them from us as we work to administer the grant with Yellowstone County. So we're going to continue to move things forward in terms of crisis response. And we still have the county mental health mill levy dollars with the county commissioners that we're going to be generating additional plans for and hopefully better utilizing those and bringing transparency, accountability, and results to this grant process. You can see there in the report, Communicable Disease Program Manager, Stacy Pinnell, a veteran of the U.S. Air Force, was recently honored with a quilt from Bernice Hash and our Veterans Support Network locally. Great honor for Stacy. We are opening our gym. It's been a long conversation about, how do we take better care of our staff? And the Live Well Fitness Center that's over in the clinic and Wellness Center building will be now open to staff. And so we're going to allow them to utilize that before or after work, during lunch, while we're figuring out how do we turn that Live Well program back on so that it benefits our patients and our community again. So more to come there. Speaking of employee wellness and engagement, I need to highlight, I will come back to the board next month and present an overview of the employee engagement survey, which we did earlier this year and the last year, and the well-being workbench assessment that we completed. But I wanted to highlight our employee engagement survey results and preliminary data for our employee net promoter score. Answer to their employees' overall rating of RiverStone Health as a place to work was an absolutely outstanding and excellent, exceptional 75. The employee NPS score is nationally benchmarked. It ranges from -100 to 100. And last year during the survey, we were best in class. Anything 80 and above is best in class. And last year's score was 88. According to the Academy to Innovate HR, the average NPS in healthcare organizations ranges between a -6.5 and 27. So it just goes to show you the incredible culture and work commitment to what we do that we have and we continue to maintain here at RiverStone Health. Moving into public health, just a reminder, if anybody has been out of the country or under a rock, RFK Jr. is now Secretary of Health and Human Services, and that is concerning. We will latch on to the benefits of that appointment as we, in community health and federally qualified health centers, are part of and recognized as a successful part of the MAHA, Make America Healthy Again movement. But on the other side, in our public health hat, it is concerning to see that we have a anti-vaccine conspiracy theorist at the helm. And so we're going to continue to do our part to manage the ever-changing political landscape and funding landscape and make sure that the organization stays poised for success. As we look at public health, the flu is at an all-time high. If you haven't noticed, if you or a loved one or a neighbor hasn't been sick, it's coming, or they're currently sick and just haven't told you. We're at our flu peak. So if you haven't gotten the flu shot, I'd say it's too late, but it's never too late to get the flu vaccine. The flu is at its peak here in Billings and across Montana, and particularly influenza A. Influenza A, the strain is particularly hard this year. So far, we've had over 400 people hospitalized and a total of 21 deaths across the state. And so it's continuing to impact our region. COVID, not too many. There's almost 900 confirmed cases since last month. So there has been an uptick. And so 130 hospitalizations and 9 deaths so far in 2025. And a note on TB, there was some misinformation on X a couple weeks ago, formerly known as Twitter. RiverStone and Montana DPHHS were made aware that there were tweets out there about a high number of active TB cases in eastern Montana. That information is false. That X Twitter thread was inaccurate, and there have been no confirmed cases of TB in 2025 yet. We typically see between 5 to 6 across the state on average on an annual basis. And we continue to monitor some latent TB, but that is not the same as active TB. And there's more information in your report on that. There currently is a large TB outbreak in Kansas, and so that's where we think some of the information was coming from, and they were placing it in different geographic locations. We continue to see syphilis rates be on the rise, and so Montana reported about 608 cases in 2024, with a slight uptick in congenital syphilis, and that's most concerning. As we talk about syphilis, it means that mothers with untreated syphilis are passing it on to their babies during childbirth. And so that's important to note because mothers aren't getting timely access to prenatal care and screenings that could prevent that from occurring. And so we're going to continue to do work there and public information campaign to make sure we're approaching syphilis prevention. And finally, I'll end with measles and bird flu, the 2 hot topics of the day. Texas and New Mexico are currently experiencing a severe outbreak of measles. As of February 25th, we've had 124 cases of measles identified. And unfortunately, this week, the most disappointing, 1 child has died, and they were unvaccinated. The best way to prevent measles is getting immunized with 2 doses of the MMR vaccine, which end up being 97% effective for your entire life. There are a number of incredibly brave families now making the difficult decision to get their children vaccinated in Texas and New Mexico. I hope to see the same here around our region. Right now, at our current rate, we are seeing high vaccination rates for MMR in our region and across Montana. However, that rate has declined over the past several years. And so the best way for us locally to prevent a measles outbreak is to have at least 95% vaccination rate across the community and across our school system. I can say with confidence that we have a very high vaccination rate within our local school district here in Billings, and so that is good news. But that continues to wane in several places across our state. So best thing that you can do is get the MMR vaccine. vaccine is safe, it is effective. And contrary to some additional misinformation this week, the vaccine did not cause this outbreak. The vaccine did not cause the infections, and the vaccine does not cause measles, mumps, or rubella. We will continue to harp on the facts and educate the folks as much as possible so that everybody can make the best decision for them and their families. And then bird flu, H5N1. There was a woman in southeast Wyoming last week who tested positive for bird flu. So it continues to skirt our region. However, hasn't yet, I didn't check this morning, but hasn't yet come to infect anyone in Montana. So there continue to be about 70 or so human confirmed cases, one death across the US. However, the recent study now shows that and we found out this information because the CDC turned on their weekly morbidity and mortality reporting system again. And one of the first reports to come out of that CDC reporting system was about asymptomatic spread among veterinary professionals. And so H5N1 is continuing to spread and can spread without anyone having symptoms, and primarily in dairy farmers, folks close to livestock, and poultry farms, and those veterinarians who work in those environments. So we're going to continue working closely with the state to monitor those situations across the U.S. And make sure that we keep our region, our poultry producers, and other folks safe. Questions?
Did the report disclose what the woman does professionally or how she might have contracted the disease?
She was a backyard poultry farmer. Yep.
Any other questions for John? Coach?
So the false report on X, do they retract it ever? Or do we post another one?
I don't know what happened to that one, but depends.
Hopefully people aren't getting their reliable information from X
Yeah.
or Facebook or Instagram or TikTok, but we know that people are using that for research. I think our best bet is to continue to send out reliable, truthful information in channels that people should be seeking information from, not social media. But I don't think X retracts. I don't think they do fact checking anymore.
No, but can we post a retraction or counter our article?
So the state did do some PR work.
Okay.
Yeah.
Other questions or comments for John?
About a month.
Do we know the immunization rate for measles in Montana?
There's information out there. Yeah. Yeah. And it varies by community.
It's getting harder to collect though, because schools are no longer required to report that information to the state government. So if you actually look at, there's been circulating a terrifying map that shows vaccines across the country, and it says Montana has like a 62% vaccination rate on that. That's incorrect. We're not that low. But the problem is we don't have accurate information because a number of school districts opted not to report that information to the state because it's no longer, there's no penalty to not doing that.
What is most helpful for you, for us as board members, especially in the political landscape and, session advocacy that we should be doing and would be helpful for us to be doing at state or national level?
Yes. All of the things. I think, when there are particularly hot button bills and items most of our work, specifically with you, Aaron, is somewhat connected. So we kind of share the same message with legislators. The hottest button things that we've worked on this session have been related to Medicaid. And so, the education that we've been able to provide to the board, to our local chamber, to the economic development folks, gain buy-in. We did a lot of work pre-session to write some resolutions and talk about, the benefits of Medicaid and other, programs. The fast and furious nature, working within our policy committee within the board is where we do a lot of that communication and building. But if there are one-off things, I think, just building a connection and saying, hey, Aaron, we're looking at this right now. How does this impact you guys down the street, and where can we work together? I think we do more one-off kind of connections. And Steve and I were talking this morning about one that's going to impact, lodging industry potentially. And so there's a lot of those one-off phone calls of, hey, who do you know? How can we talk about this to the right people?
Other questions? Hearing none. Dr. Littlefield.
All right. My report is in the chart. Just a few highlights from a provider recruitment and staffing standpoint. We have 4 new physicians who are all going to be new grads that are starting late summer, early fall. That's very exciting. We have a whole class of junior faculty coming in. We also did 2 additional interviews in this past week and have 1 offer out, and I think we'll have another offer out shortly to the 2 of them. We have a couple of new APPs, so 2 new PAs that are starting. One starting this upcoming month. They are also both new grads. We've continued to talk about, and we've talked about here, the need, not just for us, but for the community and the state to have an APP residency here. So we're continuing to work on that and what that might look like for next year. Match day is coming up. We have our rank list due at the end of next week, and then we will find out who our new class of residents will be the week of March 17th. That's always an exciting time, and quite honestly, a very stressful time for our residency leadership, but they are eagerly awaiting the names for that new group. We have some great news in the behavioral health department as far as recruitment goes. We have had the behavioral health provider at the school at senior. That position has been open for months and months and months, probably close to 6 months now, maybe even a little bit more. We hadn't been able to fill that position. We got that filled with a really great candidate. We just found out that at the end of last week. And we also hired another behavioral health provider that was backfilling a resignation that we had in December. So we have those 2 positions filled. I think there's a lot of opportunity for growth in our behavioral health team. Our plan from the school expansion framework was that we were going to, once we got senior on board, that we were going to expand behavioral health to the career center. And so we didn't want to post that position until we had these 2 positions filled. So now that we have those 2 positions filled, we'll be posting for that position. And I think there's opportunity for more expansion in that area if we can find the people. One of the big challenges that I think everyone here is aware of is just compensation and where we have fallen from a compensation standpoint. And that was some of the feedback we were getting, particularly with the behavioral health roles, was that our compensation had just fallen behind what the market was. And so hopefully we'll be looking at addressing that going into next year. Our encounters have been continue to have been going up. I haven't looked at where we're at for this month in February, but in general, there's been a trend going upward, which is really exciting. We actually have I think we have opportunities in the health center. You know, we've had a lot of changes with the RIF and a lot of changes with some of the positions, the support staff positions that sort of help do the work in the clinic, including a lot of our quality work and our value-based work, which we kind of lost ground on last year. We actually have a planning meeting today with CHC leadership to serve now that the dust has settled and we think that our staffing is a little more secure, really looking at how we want to utilize our team members to move forward with not only supporting, you know, the encounters in clinic and moving patients through the health center, but how do we refocus on this population health, which really not only improves the health of the community, but also helps with our value-based contracts. And so that will be a focus for us over the next couple of months. John filled us all in on respiratory season and where we're at from an infectious disease standpoint. We did speaking of syphilis, we had a toolkit for physicians and providers that had been developed. And we were sort of waiting to see what numbers looked like for the end of this year compared to years prior. And that toolkit and education has gone out across the community. And so that is out there and we'll continue to provide education on that.
Does the toolkit go to dentist?
Sorry?
Does the toolkit go to dentist?
So that's a great question. No, we did not send the toolkit on syphilis to dentists. There are very few. We often do include dentists in our education to providers. Syphilis is typically not something that dentists screen for. You know, there are findings that they can find and refer to providers who can test. But that's an interesting thought. I can talk to our dental team. What's your thought on that?
Thinking it should go out to them. There are some lesions, some oral lesions, and they're going to the dentist are usually covered up so they don't see skin.
Right.
But there's some oral lesions, and even the increased prevalence of congenital syphilis, it can't hurt to send it to them.
Yeah, that's not a bad idea. I think the biggest opportunity area that we have with the congenital, with tackling the congenital syphilis is really, we've done a lot of work with our EDs and sort of our walk-in clinics. Because what happens is that many women who are not receiving, so if a woman's receiving prenatal care, they're getting tested. There are new recommendations for more frequent testing throughout pregnancy. The challenge is a lot of women who are not getting prenatal treatment, it goes missed. Oftentimes, when we've looked at the congenital syphilis cases, oftentimes those women have hit the healthcare system, but it's been for other reasons. They've come in, because they were in a car accident or they fell and they have some sort of injury, and it doesn't come to mind to a lot of our urgent care providers. Oh, this person's here for a sprained ankle, let's test them for syphilis. And quite honestly, our urgent care providers really like to view things simply and in a box. They're like, treat them and treat them is sort of like their, mentality. And so ordering a test that then is going to require follow-up that's unrelated is really unappealing to them. And so we've really been trying to get out that message, test, use point of care testing. There's now point of care testing that you can do for syphilis if someone hasn't had syphilis before. Do that. And as a public health department, we are more than happy to help follow up. And as RiverStone Health Clinic, we are more than happy to see those patients and follow up. But don't not test because you don't want to, have to deal with the messy follow-up that comes with it. So, yeah. So we'll continue to work on that. The Child Advocacy Center, we actually had our first official medical forensic evaluation this week, which was, I don't know if exciting is the right word, but it's reassuring that we finally are getting that service back and running. That I anticipate that that's going to grow. We've had a huge increase in our number of forensic interviews that have been being done. And so we're not sure, we're trying to get a sense of what's going on, whether that's just a blip or whether that's a trend. So hopefully I'll have more information for you on that in a couple of months. And I think that that's it. If anyone has any questions.
Megan, if we have a gap in compensation on the behavioral health professionals, can you quantify that for me?
I think we're working, yeah.
Yeah, we have
Yeah.
we have a spreadsheet that we're gonna review tomorrow morning. And the gap is worse in behavioral health, but it's across the entire organization.
Right. So you're checking family practice also, the professionals in
Yeah.
medical professionals.
Yeah, all of it.
Right. Okay. For the newer members of the board back pre-pandemic, and I don't remember the year, we got behind on paying medical staff. And you could see the impact of that. If you didn't, a guy with my background often refers to patient care. This industry is similar to manufacturing. You're building widgets. You make one widget, you get paid for one. You make two, you get paid for two. Make 100, you get paid for 100. The widget maker is the professional. Nurse, a doctor, a PA, somebody who is billable providing a service. And if your compensation is under market, those people have a tendency to work elsewhere. So the result will be fewer patient visits, lower revenue, and a worse bottom line.
And a burnt out medical staff.
Yeah, and people get tapped out. You are, just say it colloquially, shoot yourself in the foot if you undercompensate your provider staff. I'll get off my soapbox. Any other questions for Megan? No, I won't get off my soapbox. As you make it, see vaccine hesitancy. I looked at the charts on the website the other day. I didn't see big numbers anywhere yet. What is you concern looking forward?
Well, I mean, I think as John alluded to, the biggest concern is that, so we know that vaccines protect the individual who's been vaccinated, but no vaccination is 100%. Measles is really a pretty good vaccination. And, and as John said, that's like 97, 98% effective if you've had 2 vaccines. When you look at like the flu vaccine year to year, the flu vaccine is only 40 to 60% effective, right? And so, and that's probably on one of the lower sides of, vaccination protection, I would say. Now, there's still a benefit of lessening disease burden if you've been vaccinated. And that's true with most vaccinations that you get. But the biggest protection with vaccination comes from that concept of herd immunity, is that when you have the majority of people who have been vaccinated, then the likelihood that a disease is going to spread throughout a community becomes much lower. And so when you drop below that herd immunity, which is really thought to be around 95%, that's when diseases can really circulate. And then not only are the people who are unvaccinated at risk, but everyone becomes at risk because vaccines are never 100% effective. So I think I think that is one of the biggest concerns as far as infectious disease spread. I think personally, I find the other concern with the vaccine hesitancy is really the general growing mistrust that the public has in science and particularly in medical science, right? And so I think people are gravitating more and more towards looking at X and looking at TikTok and looking at, these things on social media where they think that they're getting their research done, but, true good grounded research is more than just what a few people have noticed and then post on the internet, right? And so, and I don't think, I had, 15 years of higher education, and I still have to go back and look at how a study was done and, talk with people. Is this a good study? Is it peer reviewed? What are the confounders, right? So like the average person who hasn't had that level of, training and how to review scientific studies, might not be the most qualified to post, but evidence becomes evidence to everyone when you see it in writing. And I think that's my biggest concern with the vaccine hesitancy is I feel like it's a canary in the mine of a general growing distrust in science.
Thanks. Anyway, I've got a question. So, and maybe down the line, you could, quite honestly, I wouldn't know how to respond to somebody as a layperson. So if I were talking to my staff and saying, are you vaccinated? And they say, no, I'm not quite sure I have this knowledge, but so as you do it think about it as a layperson, how do help teach us from the medical field understand, but we as layperson don't understand.
Yeah.
How to answer the question. They can tell it's valuable, you should do it. But then, I get thrown back in my face with So it's difficult for me to respond differently. So, down the line, as part of our education, maybe some bullet points saying, I'm not necessarily going to convince them, but at least I'm going to sound a little more authoritative than I would at this particular time.
Yeah, I'd be happy to do that. And in fact, that's what we're doing with our residents and our people that we're training. Because it also turns out that me just saying to someone, and I'm smarter than you and you're looking at bad science does not change who's in life, right?
I lose the argument.
Yeah, right. Like that doesn't, even when it's coming from me, that does not influence people's minds. It's really leading them into the discussion of help me to understand what it is that you're afraid of. And can we look at some of the reasons why you might want to think differently. And so there really is an approach to how you help people to change their mind. And it's hard because I think a lot of physicians, your natural instinct is to be like, well, I'm your doctor and I know best, kind of like, well, I'm your mom and I told you so. That doesn't go over well with my, didn't work with my teenagers either. And so, I think that is an important conversation. And I think there's lots that you guys can do. So I'm happy to bring that.
Yeah.
Part of the earlier success of vaccines was fear. People who had seen these diseases and saw a way to protect their families from them. But, many of these diseases, most people haven't seen. Well, measles, for example, or other diseases that those of us who are a little bit more experienced, now I use the word experienced, have seen and have seen the consequences of those things. So it gets even new residents, most of them don't see a lot of these diseases. So we have that to fight against.
Michael.
There's a lot in here all morning on infectious diseases and immunization. And you should, I'm proud of myself for mostly keeping quiet. But I can't help it. This concept of herd immunity, I think it's troublesome and it sends the wrong message. It sends a message that, well, I don't have to get immunized if everybody else does. we should throw out the term herd immunity and simply go to 100% people need to be vaccinated. That's all I'll say. That,
Within this group, I think it's fair to discuss herd immunity in this group. We're professionals here, so.
For sure. Yeah, and I think the recognition that, to Lionel's point and others around the room, that, fear drives a lot of this, but we in public health can't use scare tactics in fear. We have to work in facts. And what we're seeing in Texas right now and New Mexico right now is a lot of brave individuals who have had deeply held personal beliefs that are now being challenged by the reality on the ground because they are seeing the infectious disease. And so they are making choices in the best interest of their kids and getting their children vaccinated when they haven't been prior or previously. And so recognize that, and we support those individuals who are seeing the impacts to kids in their schools, in their neighborhoods. And the fact that we haven't seen measles across this country in widespread fashion, the fact that we haven't seen polio in decades, the fact that we haven't seen these infectious diseases, to Lionel's point, is that fact that public health has been a victim of its own success. We've done so well across this country protecting our neighbors and our communities from infectious diseases that we're now opening up conversations across this community to second guess all of that scientific evidence and all of that progress that we've made to create healthy communities. And it's when folks and communities are seeing the diseases, are seeing the impacts of a low vaccination rate, are seeing the impacts of health misinformation on their own neighbors and their own family members, is that then they're coming around to see the benefits of what we talk about day in and day out.
Other comments or questions? Hearing none, Spencer, turn the floor over to you.
All right, well, let's shift gears, talk about financial health of RiverStone. So in the packet, there's quite a bit of information, and so you'll see a really good write-up Jenna made financial committee that was held earlier this month. So if you want a deeper dive into the financials, that's a good place to go. You also included our 3 sets of financials, RiverStone Health, which is the financial, those are the financial reports that we commonly review in this meeting. And then quarterly, we present to you the YHP financials along with the consolidated financials of both RiverStone and YHP. So I think for the purposes and given the limited time that we have here, we'll just focus on RiverStone Health financials. And if you have any questions on either the consolidated or the YHP financials, we can address those at the end. So, I think where I wanted to start, we'll just go in line as they're presented in the package with the balance sheet. I think the first thing I talk about or address in the balance sheet is just the operating cash. Cash, we talked about cash a lot. Continue to talk about cash. It remains important component of what we're doing here. It really provides us this is the stability that we need as well as the buffer we need as we navigate some of the challenges that John outlined at the start of the meeting. So, but with that being said, as you recall, last year we made some challenging decisions regarding reduction in force and so I think the one thing a significant improvement in cash. So I think that's the tremendous, that's something we should be grateful for and commend the staff for, you know, in terms of when we outlined the budget for the new year, that was something we hope to achieve, and as year to date, we've been able to achieve that. So second thing on the balance sheet I wanted to talk about is contracts receivable. You'll see that in the other current assets section, just partly down page there. You'll see our fiscal year end is 6/30, and then so we are halfway through our fiscal year as of December 31st. You see a reduction there, and that's actually a positive, because what that means is that we're doing a better job collecting on some of our significant receivables, and I think that's a testament to Shanna and her team improving the overall efficiency of collection. So I think that's a positive. Those are the two things I wanted to point out on the balance sheet. I don't have any questions related to the balance sheet that anyone wanted to bring up. If not, we'll roll right into the statement of revenue and expenditure. For the month of December, we had overall revenues of almost $5.5 million. That is an improvement over 500,000 over what we budgeted. So trending in the right direction, especially compared to the budget. On the expense side, you'll see we also we are slightly above in December what we had budgeted. That's in part due to, if you recall, during our year-end meeting, we approved a holiday bonus for the staff. So that's included in there. So that has impacted the variance slightly there. But overall, great performance. For those of you with eagle eyes that I'm sure you all poured over these financial statements before you got to the meeting, you'll see a slight change in the supplies section. We've gone ahead and started breaking out pharmaceuticals from supplies. So in the past, you'll recall when we've talked about supplies, pharmaceuticals is always you can see from this report, a very significant part of that, and a little harder to quantify how we're doing in the other areas. So we've broken it up to give everyone a little clearer vision of how that's working. And I think that'll be, helpful going forward. So, but all in all, the organization is performing well. We've been exceeding budget, so far this year. We are exceeded budget by total net revenue of almost $2.6 million. And that's the major contributor to our cash increase. So I think directionally we're doing really well. I think maybe like I said before, I think the big thing to point out is that the course that we were set on in June of last year is we're meeting that budget and exceeding it. So that's a real positive for the organization as a whole. If you look at, I pulled up the financial package from February of last year to just kind of give myself some context there. And if you compare year to date over year to date, the organization has had an improvement of almost $2 million in reduced expenses. So a testament, like I said, to the team and their efforts to control costs and to keep us online. So overall, a very positive financial performance, and I think we're definitely trending and moving in the right direction.
Spencer?
Yep.
Real quickly, on the net operating income, it's a plus number, Rand, and that includes the bonuses or staff.
Yep.
It includes that, and we're still.
Yes. Yep.
So I'll tell you how I look at it. So you have revenue from budget. You have $500,000 greater. You drop 60% of that, the net operating. Probably not. Everything's a time and place, but I will tell you, if I could drop 60% of my increase in budget, my net operating income, I'd be ecstatic. So I think and if you look at it, a year-to-date number, it's greater than a 1-to-1 ratio. So congratulations and work that you've done. And I know the year's been difficult, but congratulations. And Janet doing it. That's phenomenal, quite honestly.
As we look at the last few, I think, graphs of the financial package, you'll see just more illustration as it relates to cash. Combined cash, as well as if you look at the last graph being the days cash on hand for debt covenants. But you can see over the last 2 years, at least from a debt covenant standpoint, we've kind of skirted the edge of our 60 days, which is what we're required to have. And that measure is happens, I believe, every June. So you can see we dip below it, but June is the milestone where we have to report. So you'll see we feel comfortable that that shouldn't be something that we have to spend a lot of time and energy stressing over as the fiscal year comes to a close going forward. So that's a real positive. And then last but not least, and you'll see at the tail end of Shannon's notes, the 2026 budget is, we're working on that, or there, I shouldn't say we, I could not include myself in that. I am not working on that. Shannon and her team are, and which is I think that's a good start to get an early, very good sign to get an early start on that budget. And of course, this past year, the staff and organization made lots of sacrifices to kind of achieve what we've been able to achieve, but probably not sustainable over the long run, like we talked about earlier, relates to staff. So we're real thrilled with the performance so far this year. We're going to have to look at it a little more pragmatically going into the next fiscal year. Those are my comments, my report. Jana, Jim, anything else to add?
I would just add a couple of comments on the budgeting process. I mean, obviously the fiscal year 25 budget was a challenging one, and this one will prove to be challenging as well. 4 main things I'm seeing as far as challenges are: 1, increasing cash. Obviously in order to increase our cash balances, it's going to have to be a positive year for us. The second thing is staff increases. Just in big general terms, a 1% increase for staff is $300,000. So that's just big general terms. So looking at how we incorporate that, combined with 2 things as far as decreases in revenue. One of those coming from 340B. We're going to see some decreases in the 340B revenue that we're getting, probably to the tune of about $600,000. And then we're also going to see our COVID funds start to go away. So those are currently supplementing about $400,000 of our budget. So those big 4 things are the challenges that I'm seeing right now as we start the process for budgeting.
Megan brought up compensation. So I'll ask you the question: where do you see we've done salary surveys, so we know across the house where we've got compensation issues. Where do you see the biggest challenges, the biggest deficits?
I mean, it's everywhere. It is across the board, all positions, so we have a meeting like Jeff mentioned, and just start looking, employee by employee, going through and seeing what we can do. But it's going to be challenging to be able to get everybody to where they need to be, or, it's hard coming off of a year where the staff were not given an increase.
Yep.
But putting together some ideas, as far as how we can make that work, whether we start with an increase for everyone, or, just kind of maybe some quarterly increases based on performance. So we'll come with some ideas on some thoughts on that for the next fiscal year.
Any other questions for Spencer or the committee or staff?
Yes, hi. I do have a quick question, and that is on the indicator, the days cash on hand. In the write-up, it said that we were at like 49 days, up from 33 days, and we are supposed to be, or we target at least 60 days. So where are we today? Or is that something that's tracked every day, or is it tracked monthly, and I know that the trend is up, but where are we today, and where do we expect to be?
I'll speak to that. We track that monthly as we do our financial statements. There's kind of a little bit of confusion in that, because that 47-day number is just RiverStone Health. And so we'll end January, I suspect, about 45 days cash on hand for just RiverStone Health. The way the bond covenants have us report, it's a combination of RiverStone Health and YHP, and the calculation's a little bit different than a generic days cash on hand calculation. And that's the one that we have to be at 60 days come the end of June.
Thank you.
that measure currently is 97 days, the debt covenant rate. So we're way above the 60-day.
I will also add that that includes our hospice house sale proceeds and that combination when we include YHP. So if and when we decide to restrict that to a certain purpose, we'll lose a little bit of that extra cash combination calculation.
Other questions? We have a policy here to present to the board. Is that something for approval? Has everyone had a chance to review it? Does anyone want to give us background? Maybe Shannon?
So I think just combining a couple different things that we had done organizationally in the past into one concise document, essentially just saying, you know, we did have the situation this year where we approved the staff incentives in December. But going forward, as we look to next fiscal year, overall organizational staff increases or incentive type payments.
Okay, we need some motions to accept, 2 acceptances and 1 approval. I get a motion to accept the committee notes.
So moved.
Second. All in favor?
Aye.
Aye.
Opposed, same. A motion to accept the financial statements.
So moved.
Second.
All in favor?
Aye.
Aye.
Opposed, same sign. And a motion to approve the salary adjustment and compensation policy.
So moved.
Second.
All in favor?
Aye.
Opposed, same sign, please. Great. Thanks to Spencer and Shannon. And thanks to the finance staff. Lionel, are you ready to talk to us from afar?
I am. I'm in, at least for me, cold Tucson, Arizona now. And have been, Phil.
Lionel,
Yes, sir. Anyway, so I have reviewed the minutes from the quality committee. I was not there because I was avoiding the cold here. But there were 3 main topics discussed: organizational innovation, risk and compliance, and public health, workforce standardization. And so I'll just highlight maybe a couple of points under each one of those. You know, our ECW optimization project apparently kind of ground to a somewhat of a halt. Apparently, it didn't turn out as we had hoped, and so there's a refocus on how we use that electronic medical record. You've already heard about the mobile unit and the Child Advocacy Center, so I won't get into that. Under risk management and compliance, we reviewed the 3-year trend, and the top 5 incidents haven't really changed very much. I'm happy to say that what has improved quite a bit is there used to be an item that said other, and that was sort of a wastebasket for incidents not classified, and that is essentially gone, or at least it's very small. So the staff has done a good job there. Our fluid incidents have gone way down, mostly because the hospice house, which is where most of those incidents occurred, is no longer. There was a root cause analysis done on a STD, a sexually transmitted disease, because there was a case that occurred, and the root cause analysis pointed out some problems in coordination between the clinic and public health people, and so it provided an opportunity to improve that. And then finally, under the public health workforce, you know, we have a diverse workforce there, and in terms of what they do and their training and all that sort of thing, and the challenge that they have there is to come up with some standardization as to how people are oriented and trained and inculcated with our particular workforce values. In particular, we need to have a workforce plan in place as a requirement of our accreditation, and I guess we meet that requirement. So that was essentially what is my understanding what occurred at that meeting. I think John Doerr was there, and maybe he has other comments, but that's what I got from the minutes.
Mr. Michael, comments about the meeting?
I think Lionel covered it well. And I have a question for Lionel.
Yes, sir.
Have you read Atul Gawande's better?
Say that again. I'm sorry.
Have you read Atul Gawande's book Better?
No, I've read some of his other work, but not that one.
Okay, I've got a copy for you, and I think we should give it to the leaders of the quality team as well.
Okay, sounds good.
You read it.
Okay, very good.
Other comments, questions for the committee? Hearing none, can I get a motion to accept the board
So moved.
committee minutes? Thanks.
Second.
All in favor?
Aye.
Same sign. A policy committee.
Okay, we looked at 4 different issues, all of which are pretty much continuing. First one is legislative process, both on the state and the federal level. With the election in force last year, John Forte is in that area, and since our meeting was 4 months ago, it's anything we discussed then is pretty much out of date. But John, do you want to give us an update?
Continue to update. Yeah, they come fast and furious. It seems these days. So there are a few bills of note that are in here for conversation. There are several other bills that are out there at the moment being reviewed, both from a public health standpoint and a clinical standpoint. In the clinic, some of the hot topics this week have been on the Kratom Consumer Protection Act from one of our local legislators, Nellie Nickel. And we actually had a fairly decent meeting earlier this week with the kratom industry. And there's a disconnect between what's being written at the State House and what industry and public health would like to see come out of this regulatory process. And so one of the biggest problems with kratom in our community currently is that there is a lot of synthetic kratom substance out there that is highly potent. Off the track, say is highly potent and incredibly unregulated and frankly unsafe. And that synthetic kratom is the type that you can get in pill and powder form at your local gas station or tobacco and vape shop. And so we're trying right now to work across with the industry to regulate that synthetic substance and get that off the streets and out of folks' hands, because it is highly dangerous. The other thing that we're trying to do is work through the current illegalities of inclusion of kratom in local licensed food establishments and sold in mostly beverage form, pre-canned and distributed locally and across the country and marketed and as an alcohol alternative. But per local Montana food code and per federal food code, those substances are not allowed to be sold in a licensed retail food establishment at this present time. However, we have that occurring across the nation and across our region. And so we are working with, again, industry partners, food establishments, bars, the state, and others to try to rectify that situation and make sure that we keep the public safe. So lots going on with the House Bill 407 and the Freedom Consumer Protection Act. There are other bills out there that are happening. HB 525, looking to revise laws around nicotine and vapor products. That is a specific Altria tobacco industry bill that we're watching. Currently watching other bills out there regarding Clean Indoor Air Act and tobacco, how our tobacco prevention funds could come to us or be taken from us in terms of cancer prevention and educating teenagers about the dangers of tobacco use. And there are several other bills out there that are seeking to limit public health authority when it comes to sewage and leach field permitting processes, when it comes to reviewing childcare facilities, daycares for doing their health inspections, and then others that are out there looking to adjust how boarding houses and tourist homes are inspected and licensed by Health and Human Services. So there's a lot of bills out there being written and proposed to just continue to chip away at public health's role in keeping our communities safe.
Thank you. And on the brighter side, the Medicaid expansion seems to be
Yeah, now shifting to the good news. Only a new state. Yeah, so Medicaid continues to move through. It passed and cleared the House earlier this month. We're still in February. Then it was continuing to move through the Senate. It has been passed off to a finance committee in the Senate for review, and we expect that review to take place pretty rapidly. It'll go back to the Senate floor for the third reading, and then should be codified and successfully passed through to off to the governor's desk. All that being said, I think from this process, we can see that the Montana legislature overwhelmingly, understands the benefits of Medicaid and Medicaid expansion in the state. The governor and DPHHS obviously support and understand the benefits of Medicaid and Medicaid expansion in Montana. Now our fight will move to our congressional leaders in Washington to make sure that Senator Daines, in his leadership capacity in the Senate, understands that his constituents support and need Medicaid and Medicaid funds to continue to be provided by the federal government to support Montanans. And I know that our friends in the House of Representatives also see the benefit of Medicaid, Medicare, and Social Security. And so it'll be very interesting to see what happens at the federal level now regarding the federal match, or the FMAP. And so that FMAP is the amount of money that the feds put into Medicaid expansion. And so right now, that is a 90-10 match. And so 90% of that fund comes from the federal government to allow for expanded Medicaid to exist in the state. Our bill locally at the state house level has a trigger clause. And so if anything changes with that FMAP, the percent of the funds that are given to us from the federal government. The Montana State Legislature has to go into a special session and review our bill and determine how we're going to pay for and if we're going to pay for that expansion population. And so that would have to come out of the state budget and be funded through the Department of Health and Human Services locally. So while we're optimistic that we'll get Medicaid expansion through and reauthorized through the state, we are now at the will of our federal Congress.
Thanks. And we're supporting with the work requirement, and I guess I don't want to put you on the spot, but I don't think I've ever understood what the work requirement is, because on the surface, it doesn't sound too onerous, but apparently it doesn't affect many people. But
Yeah.
Explain that.
It shouldn't be very onerous. And it's my personal and professional question that I have always asked our state legislators who are supporting this work requirement is, what problem are you trying to solve? And why are you spending money to solve a not? Because frankly, over 82% or more of individuals on Medicaid in the state of Montana are working. They are employed. They meet the requirements of the program. And so the vast majority are working and employed and meeting those community engagement requirements. What this is going to do, should those be affected or put into effect, is just create an additional spend for the state to have to employ additional people in DPHHS, to put additional technology systems in place to monitor the work requirements and basically enact the system, and put in another layer of bureaucracy when I thought that's what we were trying to avoid, specifically in Helena. And so, again, I asked the question, what problem are we trying to solve, when one really doesn't exist? There's a small minority of people that fall into that category. So we'll continue to monitor it. But I think the fact is that we support whatever gets Medicaid reauthorization across the finish line. And we're going to continue to be, as we have for the past decade, strong supporters of making sure the right people are on Medicaid, and that the people receiving the benefit are those that need it and deserve it, and need that to access healthcare. So we'll continue to do that.
Thanks. So in Georgia, they tried to institute one of these programs, and they found out it cost them much more than they saved.
Good, thank you. The other issue that the committee considered, the second was the issue of a kiosk, one particular one, which involved above city code to be a mobile unit, and therefore the permanent thing. Basically, the result is we're re-examining those regulations with regard to kiosks and the size of the units in terms of what can be served. The third item we talked about was the continuing idea of grading somehow the food providers in town. This step, what the department is going to be doing is going to those providers to try to get feedback, so that eventually a person will be able to go to a website and tell, what is a reasonably healthy restaurant and what is not. And then the last item we considered was the having a kratom issue, and John has already discussed that, so given us updates on that. So that's it for our committee.
Any questions for the committee? Hearing none. Motion to accept.
So
Second.
In favor?
Aye.
Okay, governance did not meet in the past month. For those members in the room or online, I'll be calling a meeting ex post haste. Within the next couple of weeks, I'd like to get the committee together, go over a few issues.
Could you speak English?
No,
He's the counselor.
any old business to come before the committee, before the board, I'm sorry. Or new business.
I have a question for John. Seems like we used to get reports under new business as to new things being developed in the organization. And for the last several months, we haven't heard any. Are we overwhelmed or just not starting anything new?
We are overwhelmed. They're trying to keep up with all of the chaos, Scott. And so I think we've been trying to keep the wheels on the track and keep things moving forward. And we'll have some new business board education coming up soon.
John, can I make a comment?
Please.
This new administration change has caused significant review and disruption in our operational stuff, and we're reevaluating and looking at a lot of things. So it's really hard to get our hands around all of the things that we're trying to figure out right now. That makes sense?
Oh, yeah. That's why I said, are we overwhelmed?
Other questions or comments about the meeting? Michael?
Yeah, overstepped my governance responsibilities just a little bit. There's a lot of information from time to time. Child Advocacy Center, Kids Connect, other programs that revolve around children. I hope we can look at our budget carefully when we're trying to find money to support programs. And I think these are really important initiatives that make us stand out and do something powerful for our children in the community. And I hope we can find resources to support them. I know I'm out of line, but I don't mind.
Not that far.
That's all.
Gender-based violence and victim services and child advocacy centers are one of the things that are under fire in the new administration. I don't know if you've experienced this. I know we have a lot, and right now the landscape of what that looks like going forward is very unknown and concerning.
Yeah, we're going to have a lot to look at and think about. I think the other two programs that are at risk are WIC and SNAP and TANF and, food insecurity programs, other wraparound services. The grant for the Medicare, Medicaid, CMS health insurance navigators has been pulled and withheld. And so that program through Cover Montana across the state, program that helped get individuals on other insurance plans and programs is now at risk. And so at a time when we're having these conversations about pulling people off of Medicaid rolls and trying to get them other coverage, we're taking away the support system and network and ability for those individuals to get on other products and other coverages. And so we're cutting off our hands and cutting off our heads at the same time. So it's going to be interesting. We're going to get creative and do what we can to keep moving forward.
How are the feds going to address Medicaid expansion? Figured that one out yet?
Nope. 880 billion out of the House reconciliation package cut from CMS. So that's all signs point to Medicaid cuts, but we'll see. We'll see. Right now, it's nobody knows because of the politics that are being played. Yeah.
Any other comments for the general board? Thoughts about the meeting? Lionel, or I see two other people signed in. Are there other comments from The remote locations,
Except Carrie's not really remote.
Yeah.
I don't have my glasses.
They do help.
I would tell you the one comment that didn't really get much play was the fact of the turnover rate that the organization has experienced. Once again, I think that's a phenomenal turnover rate.
Yeah.
In this industry, quite honestly, any industry. So it goes to, I would say it goes to this senior leadership team. It goes to the culture. It goes to a lot of things. It's more than just the culture. It's the way things are applied. So congratulations. I think that's huge. Those are dollars people don't see. You know, it's sort of like oil filter, pay me now, pay me later, kind of. With the turnover, you see it, but without it, you don't see it. So congratulations.
And Steve, I'd also add in there care in hiring,
Oh, yeah.
picking the right people.
Absolutely.
And all of that in light of salaries that really could be or should be higher. It's remarkable.
Yeah. Good point, Lionel. Facing the challenges that we do, organization, we still have very low turnover. So kudos to the SLT.
I'll add one other thing. From my previous employment, going through a lot of reduction in forces over about a 5-year period. And I was with, turnover tends to go up really high too, because people want to get off of what they think is a sinking ship.
Yep.
That didn't happen here. And I think it's a credit to, the entire leadership team across the organization for trying to reassure folks that the best we can, it's a one-time thing. We've got to get through this. We have to get to a healthier financial situation, and the communication was good. So I think that helped us through it.
Thanks, Jeff. That's a good point. Kudos to John and your communication to the organization about what was happening last year.
And I had a question for Megan before. With our advanced practice residency, would our neighbors up the street be willing to help us fund it?
Yeah, I think that that's one of the things that we should look into. We have not really started significant conversations with them about that in the past.
Well, because I think that, and the fact that we trained a number of new graduates that they then get, I would think they should be willing to help.
I mean, I think the reality right now, we're doing that for them for free. So it's sort of like one of those things where, do you want to pay for what you've been getting for free? Because we take new grads. They really don't take new grads.
Yeah.
So we take new grads, we train new grads, we stay here for a couple of years. And then I would say in the 15 years that I've been here, almost every person that has left here has gone to a higher paying position in one of our other health systems. And so, yeah, I think that's going to be the challenge is now, we're going to be like, do you want to help pay for something that you're getting for
Or
free?
we may not be able to continue training.
Right. Except then we can't hire them. That's part of the, I know, we don't need to necessarily share that information, but when our starting salary is, right, like that becomes a challenge, right? When we talk about the differences, our APP salary is significantly, the other places in town. And so is our physician. I mean, every salary is. So is our physician salary. Our residents graduate here and go up there and get paid more than their faculty do. But we are a great place to work. And I say that, I mean, in seriousness, I think that, yes, we need to increase compensation, and that needs to be a priority, but we are never going to be able to compete with most of those positions, like dollar for dollar. We just are not going to be able to do that. And so I think that compensation isn't the only factor. It's a factor. But we also have to continue. I mean, people do leave and then come back, in other roles and say, you know, I went up there, I tried it, the culture is much better here. The mission of what we do is much better here. You know, the teamwork is much better here. It's unparalleled. And so I think we need to continue to focus on that.
So we need to make those people spokespeople.
Right.
I think one other thing that, and I just saw it on an exit interview yesterday. It's been a perception, and because it's a reality, that our benefits here are way better than most organizations employees have worked at prior. So that doesn't make up the compensation gap, but it does help retain to a certain degree the folks that want to stay here because of the culture too, and the pay that they're getting. So it's another spoke in the wheel, I guess.
Yeah, it's hard to get future pay to cover the rent.
Yeah.
Yep.
Yeah.
Jeff, what components of the benefit structure seen as being better than the competition?
I mean, there's a lot. I mean, one of the things we do here that, now, I don't know about some of the health organizations, but, you know, we cover for full-time employees the premium. So there's no premium payment whatsoever through your health insurance. We have just a myriad of other things we just added. We have a pretty robust PTO, I'll call it, even though we have vacation, sick days and that, we actually have them broke down like that. We added a big volunteer day last year that was received quite well, so they can go out and, you know, give back to the public and folks like that. I mean, it's not just that I'm getting paid, it's they like doing something beyond their work. So, and I can go on, but yeah, there's a lot of, I mean, we could put together just a bullet points of what benefits we offer, and John wants to bring that to the board. You guys can see that.
So Jim, on the provider,
Yeah.
on the provider side, most of these larger systems treat them, the providers look at what are seen, look at their job more like a profit center than an actual medical practice. And that's okay when you're making good money, when you're getting started, but it really tires you after a while. And so you get kind of on this revolving treadmill. And one thing that RiverStone Health does is have a very personal connection between its medical staff and its patients and its administration. And it's really good. I attribute a lot of that to Eric and John and Megan, who have actually created really good staff relationships. So I can call my doctor here at RiverStone Health pretty much any time, and he answers me and calls me back. There's just something about that profit center kind of theory that really ticks off family medicine practitioners, in my opinion. So.
And not just family medicine. The other guys I've talked to. So,
yeah, nobody just wants to be a widget.
Yeah. Shanna, you had a comment.
Just a comment about benefits. One of the things that's really significant for us organizationally, and it's expensive too, is the PERS, the retirement contribution.
Yeah.
So we're part of the county's obviously benefit structure and plan. And so that requirement is that we contribute 9.07% into that retirement for all staff. And historically, we've seen that go up 0.1% each year. We haven't seen that the last couple of years go up that 10%, but that's a requirement. And so that's pretty significant as far as an employer contribution. Along with that, though, employees are required to contribute 7.9% required. And so that's hard for employees, like we were just talking about. It doesn't pay the rent, right? Like they have to take that out of each paycheck. But in totality, that's a huge benefit.
When do they vest in PERS?
5 years.
Yeah, and you have to get to 5. There's no graduated. If you get some of it. You don't get to 5, you don't get it. Well, you get your portion that you put in, but you don't get the employer portion.
Is that a pension?
Yeah. Yep.
Two
PERS is
different
the
There's two different
defined benefit plan
Yeah.
for public employees here in the state. Stuart, what do the hospitals up the street do on health benefits? Do they pay 100% for full-time
I don't know
employees?
the answer, but I can find out.
I doubt that they do, but I
doubt
don't
that
know.
they do.
Just to clear, Jim, we have two. There's a defined benefit plan and a
Defined
deferred.
contribution.
defined contribution. So one's more like a pension, one's more like a government version of a 401k. And, but they're both matched at the same amount, right?
Yep, and then there's another 10% put in by the state, so it's pretty significant.
Yeah. Thanks, Eric, for that clarification. Other comments or questions? Good dialogue.
Debbie?
Yeah, I was just wondering with the DEI verbiage, federal, does that affect our agency at all, taking that out?
So now the executive orders are null and void.
Okay.
And so we're in the clear. Next to the judiciary.
Yeah, nice.
Today, yeah. Yeah.
As of
Yeah.
8 a.m.
Yeah, as of 8:40 a.m. on Thursday, the 27th, yeah.
Other questions or comments from the board? Hearing none, we are adjourned.